Good morning, everyone. Welcome to the webinar Thriving in Substance Use Disorders, Service Delivery in the Post-COVID Era. Again, thank you all of you for being here and supporting this webinar. My name is Andrea Hebler, and I will be helping with facilitation today. And before we start, as always, I want to remind you that this session is being recorded for later distribution. If you need captioning for this class, you may navigate to the bottom part of your Zoom windows and click on the captioning feature. There is a Q&A box in front of us, and that is our interactive tool that we have for all of you to drop your questions there. As you know, during these webinars, we cannot see you. Your cameras will be off, and we cannot hear you, but we will be looking to the Q&A box to make sure that we can gather all your questions, and our speaker will address each one of them as she goes through the presentation or maybe at the very end of the class. So once again, thank you all of you for being here. And today we have a very special speaker with us. We have Dr. Lesley Manson. Dr. Manson is not a stranger to many of you, I'm sure, because she is an important part of our hub of experts at the Systems and Sustainability Eco Series. She's a doctor in psychology. She is an associate professor at Arizona State University, and she has dedicated years to directing behavioral health organizations. And it's a true pleasure to have her with us today. Dr. Manson, how are you today? Welcome.
Thank you. I'm great. I'm so excited to be here with all of you today. And I want to encourage everyone that as we move forward in the webinar, please go ahead and post your questions so we can try to answer them right away for everyone.
Of course. And I think we can start with the presentation. We're going to start sharing the didactics. There you go. All right. Whenever you're ready, you may briefly introduce yourself and let's dive in. Thank you.
Thank you. Well, great, everyone. If there's any time that you can't hear me anything, let the host know so I can make sure to fix anything that's happening as well. But welcome, everyone. Today, we're going to be discussing post-COVID and long COVID and the impact on behavioral health and substance use, and especially related to telehealth care. Next slide. So today we're going to be going over a variety of things. We're going to be talking a little bit about COVID and long COVID as well, and its impact specifically on mental health and substance use. And we're going to be discussing telehealth options as well, and how to really systematically set up for success related to that as well. Next slide. We do not have any disclosures, so we have no relevant financial relationships for myself or for the planning committee, just so you all know, for CE. And then let's go ahead and start to dive on in. There's a lot of information I want to go over today, so we're just going to start off. And I do want to emphasize all of these slides will be open to you all in a PDF so that you can have and review at your leisure. And some of them I'm just going to refer to you all to be able to look at them later because they have a lot of information and links for resources and such for people. Okay. So we're going to first start by just talking a little bit about long COVID and the impact of COVID on our society. So I just want to first state that long COVID encompasses over 200 different symptoms, and they're variable and wide ranging. And they relate and impact multiple systems. So respiratory, cardiovascular, multiskeletal, gastrointestinal, neurological, dermatological, and of course, psychological, behavioral, psychiatric, which is neurological, right? So they really impact our full body. And so we've seen a significant increase in mental health symptoms. And of course, we also saw substance use symptoms increase during the pandemic and now post-pandemic. Some of that's changing again, but right now there's still a heightened need. Okay. Next slide. I really want to point out for everybody kind of what we've seen related to mental health and the symptomatology that's been happening. And so there was about a 25% increase in anxiety and depression compared with just general pieces. So just in the pandemic alone, compared with normal ranges of mental health symptomatology, we definitely increased that. Now, we know that already because we had pandemic fatigue, we had significant bereavement, we had significant amounts of loneliness, okay? We did have a slight decrease in suicide completion or deaths by suicide during the first year of COVID, and that's because most people were next to someone. We were sometimes within our homes with others around us. And so you'll see a little bit of dip in deaths by suicide during that, and then they've increased again substantially. And so unfortunately, they've been on the rise since 2021 on. So just to kind of, note that for folks as well, if you're looking at some of the data. And purely they believe that dip in lowering them is because we were next to people. Connectedness is one of the key pieces that are so important for ourselves and our overall health. And so that really played a role when it came to death by suicide. Okay. But as we look at this, we are seeing more and more studies coming out. There's been meta-analysis studies around the world showing that there are more people who are experiencing things called long COVID symptomatology, which includes a higher rate and percentage of mental health and then difficulty with coping. So what's happening is that they're having an increase in substance use behaviors as well. So just to kind of put that out there. We also know that individuals who are hospitalized for their symptoms are at a 60% higher rate of having these mental health and sometimes substance use concerns than our general population. Okay. Next slide. So this is really important for us when we're considering care for our communities is, okay, if we know there's a direct correlation with long COVID in specific, those symptomatology and mental health and potentially substance use with this, we need to be looking at COVID as a potential impact for our population. We need to be considering, are we screening for it? Are we asking our patients that? How about when they're coming in for substance use services? Have we asked them, have you had COVID? Have you had COVID recently? When? Did you notice any changes since you had COVID, right? And any of your patterns of use or any other symptoms? Because of how it's impacting us neurologically, and I'll go into a little bit of that, is making us have more difficult time being able to choose healthier coping strategies, think through decision making, okay? So it really is important to consider this, as well as for our mental health agencies and public health and medical health agencies to be asking these questions because of how tied it is to general medical symptomatology. And then, of course, as I've talked about earlier, our general mental health symptomatology. So things like anxiety, depression, et cetera. We want to be asking if they've had COVID and if they have any type of long-term symptoms since then. Okay. This will help us differentiate because right now we don't have a clear ability to be like, oh, we'll prick your finger. Oh, now we see you have long COVID. We don't have that, unfortunately. So it's very difficult to weigh through, but there are specific types of treatment that they do recommend, specific interventions to build into all public health, mental health, and substance use programs that help these individuals who are struggling with this. So I'm going to go over those today too. And all of those can be done, and most of them are being done through telehealth, which is wonderful because since COVID, there's been an increase in our telehealth services as well. So we know that the mechanisms of COVID-19 and its impacts they're still being studied and explored. We still have large-scale studies, especially for children and MISC. So we're looking at all of these impacts for our community still. But we know in general, individuals who have long COVID have a variety of symptoms that are just continuing to increase and they're continuing to experience throughout the years. Typically, on average, it's about a 6-month a picture of intense significance of their symptomatology. And then after that, it does start to reduce. So that's important for folks to know. But it's also important to know that we do know that some folks, it just continues to maintain. And so that's why we really do need to have these levels of intervention for people. There are some studies that actually show that individuals who are hospitalized for any of these symptoms have, some studies have showed a 90% occurrence in a significant impact of these symptoms for patients. And these are patients who didn't necessarily have these symptoms prior as well. So now after they're experiencing these long-term and long-lasting symptomatology. So it is important that we're starting to look at these pieces. Just to kind of give a brief overview, we know that fatigue is one of the number one symptoms that people talk about, along with depression. And then, of course, we have cognitive impairment as a significant one. Over 65% of people experiencing difficulties in cognitive impairment, which is directly related to substance use and other pieces, as I'll talk about the reasons why. And then along with OCD, sleep impairment, PTSD, and then other more heightened pieces. Directly, there's an increase in substance use, just in direct piece of that without the other symptomatology as well. And of course, with individuals, some people have had psychotic episodes as well who did not have them prior. Next slide. Now, just to kind of give you a little bit of a reference, hit the next slide. Oh, there we go. Oh, I'm sorry, go back one. It looks like it skipped. I might have, there we go. Might be a lag. There are a lot of hypotheses related to COVID and long COVID symptoms and how they're impacting people. And I just want to kind of highlight a couple pieces here because I think it's important to recognize what's happening with our populations and our communities long term. So it has impacted our central nervous system. And so through a direct and non-direct way. So that means through viral invasion for folks, and then through things like inflammation, et cetera. Okay. And all of this is impacting our ability to be able to cope with scenario situations. And then, of course, just general mental health and cognitive health for us. So it really does have a systemic disruption for our bodies. Okay. And they have actually talked about how there's specific neuroinflammation and autoimmune dysregulation for individuals who experience COVID, and then for individuals who have the long COVID symptomatology. So that's just ongoing for them. We have seen with neuroimaging and specific EEGs, structural and functional abnormalities in the frontal, temporal, and limbic areas of the brain. And if we think about that in specific, we can start to recognize, okay, here are the exact reasons why individuals are having these symptoms related to mental health and substance use. So we also have seen a greater reduction in overall brain volume. Okay. Now, just a note, that's also similar for patients who experience PTSD and other types of mental health. There's actually a change in brain volume that can occur. So we actually see changes in gray matter, et cetera. But with COVID, we also see widespread disruption of microstructural brain integrity, okay, hypometabolism, and frontoparietal and medial temporal area problems. And that's where we get those mental health symptoms and the difficulty with being able to pause, make clear decisions, walk through decision-making in our brains before we actually do something, okay? So that's really important to recognize too, so that also when you're thinking about treatment, so some individuals may need a little bit more specific types of interventions to help them with that type of decision making, and more likely they're going to need environments that do not have specific things around them that they can partake in that might be unhelpful for them. Okay. Next slide, please. So we do know, just really quickly, there's an increased risk of mental health associated with specific types of populations. And so we can look at this. We have people that have been hospitalized, as I mentioned before, are one. Anyone who has a severe illness when it comes to COVID-19, we're seeing a reduction in that, but we still see some folks that do have severe symptomatology with COVID-19, especially if they haven't, had it prior or anytime recent, if they have other types of chronic diseases, if they are autoimmune, et cetera. We also see it in other specific populations: Black, Hispanic, Latino, American Indian, Alaska Native, and in women. All of these individuals actually have an increased risk for ongoing symptomatology. And so that's really important to note, just to kind of look at all these areas. In fact, if you're someone that also provides services for individuals who have intellectual disabilities, they're at one of the highest risk factors for ongoing symptomatology and more concerns related to mental health and substance use from COVID. So we've seen that an increase for them. So not only from the pandemic, it was the number one reason why that population died was COVID, but even after, we're seeing a significant increase in their mental health, and specifically also in suicide attempts. So it really is important to be looking at these populations. I see a question that came in. Is there a difference between long COVID symptoms for individuals that experience COVID once versus multiple times? That's a great question, Laura. So there's a lot of debate on that. There are some studies that have tried to look at that. The number one concern when we look at this, that not only the researchers have noted, but individuals looking at the studies have said, is we don't have an ability to really be able to clearly say, oh, you definitely have had it 3 or 4 times. We have very low amounts of information on people that actually have the date, time, the test, and it's clear to say, I had it 5 times, here are the dates, here are the tests, right? Rather, we have populations that are entering these studies that are saying, oh yeah, I think I had it. Oh yeah, I had it. When? Oh, it was sometime in December because it was a holiday. Did you test? No. Or, yes, for some instances, but again, we don't have direct ability to link that for the research. The information is just, it's not firm enough. So they haven't been able to really identify that, nor because they're not coming in for studies at that time, we don't know what strain they have. So then the study ability to really look at that is, again, strained. There are multiple strains still out there that are impacting people, and some of which are in a little bit of different ways as far as the symptoms. So what we do know is if you come in and you've had different types, they're going to operate differently. It could be because you have different picture of your own health, right? If your own health has some sort of different autoimmune pieces, because you have a certain strain, you're going to get different symptoms, and those might last long term because of your underlying conditions, right? So you might have more dermatologic symptoms because you have psoriasis, right? And that might end up kicking it off to have more significant impacts on you long term because of the underlying pieces. So it's right now, we have nothing direct we can say other than we believe that is true. But again, when we look at the studies, there's no direct evidence because there's no ability to collect that data well. They're trying to do that with the MISC studies, where they are bringing in kids, it's across the world. And they're bringing it, you have MISC studies in Texas as well as in Arizona. There's a few states that are doing them, and they're sponsored by our government as well as the World Health Organization. And so we're really trying to look at kids and helping to see if we can get a look at that. And so they're being tested and looking at which variant they're having, how often, et cetera. So hopefully from that data, maybe we'll get a little bit more information. Okay. Okay, so the next piece we have is we're looking at, next slide, sorry. Just so I can keep moving. The next thing we're looking at is increased risk factors. So there's a variety of increased risk factors. I went over the populations that have increased risk factors, right? So we know about that. But we also just want to kind of point out that we have increased risk factors just from the fact that we've had a pandemic, right? Now we have a lot of folks that have gone from social isolation, even though maybe perhaps they were forced to stay home. Children had less connectedness, right? Because of the isolation, sometimes at home, not with other peers. Then after the pandemic, now they're out and about. But we have social disconnectedness as well, with an increased use in technology, social media, all of those things. So unfortunately, we don't have a really good setup right now to be able to support everyone to greater elements of health. We have a lot of risk factors related to it. So we do want to kind of look at those pieces, especially when we're trying to look at evaluating people that are coming in for care and where they have connectedness. Where are they getting support, right? Or were they lacking it? Now, studies do show if you can get support through telehealth technologies that is healthy and appropriate and safe, then that can be a really good avenue to be able to provide support. So just to kind of put that out there as well. But we are seeing increase in symptoms. And I just want to kind of note this, even with children as young as 5 since the pandemic. So we had an increase in mental health symptoms that we've never seen before. So that's really important to recognize. And that's way and above our general averages and changes in healthcare. Okay. We also saw an increase in domestic and interpersonal violence cases. Okay. Since the pandemic, we had an increase to almost 33% globally. And so these things are all really important to recognize. And these are all contributing factors. Also, when we're looking at not only at mental health, but also at substance use as well. Okay. Next slide. So this is just an interesting study. It just is happenstance. I'd like to point it out. So it is in our references, so you can look at it. It is really an interesting piece that we do. There's a study, as UPenn and researchers have been doing different studies, okay? And they were doing some studies related to MRI scans. They happened to be doing one from 2016 to 2019 on teen brains, happenstance, right? And then COVID hit. So then they were like, let's go ahead and look at these folks again. Let's go ahead and do teen brains again right now from 2020 to 2022. So they have a comparison, right? From what we think of, pre-pandemic kind of, after. So that 2020 to 2022 range. So then they looked at that. So that's kind of pandemic range, but they had a great comparison, right? So this is all happenstance. But it's interesting, what they found was pretty significant. It's those pieces I highlighted before. And they found this in children and teens, which is really kind of a dangerous piece, knowing that we have heightened need for treatment for these populations. So they found that the hippocampus, the amygdala, all had high, unusual and high growth activities. And these are the areas for memories and regulation of fear, stress, and emotions when we think about it, right? So now think about their ability to cope and manage health symptoms in general. These areas, when they have higher volume, we also know they're tied to behavioral disorders, okay, for people, so for kids and adolescents. So again, more reasons why we have a real high concern right now around the world with this. So again, when we look at this as well, it's also, they saw thinning in tissues in the cortex, which is involved within our executive functioning, which is why I keep stressing that a person's ability to think through and make decisions, right? So they also indicated that their brain age on average was older than other generations. So they said that they had more significant advanced brain age, not a good thing, not like, oh, they're so much more intelligent, more of they're so much more declining in different ways and not fully functioning and how they should be. They also had more symptoms and highlights in their brain related to anxiety, depression, and that's untypical of any times that they've seen it before. So it's really important, they emphasize, to start doing much more screening than we ever have, even though we know in the past, 10 years, we've been told we all need to be screening for substance use and mental health in all areas, right? No matter who you are, to be dentist office, right? Public health, just general physicals to chiropractic care, everything. This is more of the reasons why. Okay, we don't know, we have not seen the study done again, so we do not know if these brains have now gone back and they're all repaired again. Yay, we do not have information on that. They are looking at doing another large-scale study related to it, so maybe we'll see that in another 5 or 10 years to come out, which will be really interesting to see this. Okay. I can go on with more of this research, but I'm just going to kind of move forward a little bit, okay? We know that there's a lot of specific mental health sequelae, so a lot of symptoms that occur. So here's just the link of the different types of symptoms. If people have specific questions, I can definitely go into some of the percentages related to it. But just know there's lots of symptoms that are happening for people that could be part of a different picture, not only from long COVID in specific, but also just from the pandemic that's occurred, right? Next slide. I mentioned before that because of the pandemic, there's been a huge amount of stress. We need to continue to assess for that because recently specific pandemic aids across all of our states in the United States have changed. So we were still giving out some things like housing support and other things that were happening. And in most states, that's going away or has gone away this year. Okay. I know that in some places it's going away at the end of the year, but in most states it's all gone away this year. So it is really important to recognize that there's most likely an increase in different types of stress for people. So that's related to their housing, other type of social determinants of health aspects, ability to access food, safe areas, etc. So what does this mean for all of us? Next slide, is that truly what's recommended across the world is we look at other ways to provide care. So in specific, providing care through telehealth has been recommended to really enhance access. We've seen it be able to enhance access to rural and frontier areas, as well as in major cities. And we've seen an increase in utilization for actually our older and aging populations. So they're actually, as much as we thought they wouldn't like it, they've actually indicated that they'd like to use it more and are using it. They may have more difficulty using it, but they actually like using it and like having the access to use it. And of course, with our younger populations, we are seeing that they are preferring to use it. So in fact, there's a lot of folks that are moving to some of the chat-based applications through their healthcare agencies as well to try to outreach to those younger populations. There's also a recommendation that we link with multidisciplinary teams. I know that we can't always do that, but through telehealth, perhaps we can connect with other types of healthcare agencies or people in other ways to really be able to bring on a team-based approach for someone. So that's something to really consider and look at how you're approaching care. I'm going to talk a little bit about the ways that they specifically say for interventions here in just a moment, and then I'm going to go into the technology for telehealth. Okay, so next slide. We do want to always say that we need a trauma-informed care approach, right? And I'm going to say that because when we look at the pandemic, they are seeing the pandemic as a trauma and as an impact for most people in the population. Now, there are some people, like with any trauma, will say, oh, you know, I might have a few symptoms, I get better and I'm fine, or I don't have anything related to that, right? We still are looking at less than 10% of people who have a trauma actually have significant impacts to their mental health or physical well-being, right? From like a PTSD type trauma. So when we're looking at this, it's the same. We still want to look at it through that lens. There may be lots of folks that don't have a problem or don't report it, but that doesn't mean that we shouldn't kind of look at how we are approaching care in that trauma-informed way. We should approach it in that way, not only because we have the pandemic and that's seen as a major trauma indicator for people, but also because we know that we have huge concerns related to social determinants of health, and that is a huge impact on our communities and their ability to have and access and gain care. So we really need to be able to be thinking about how we're approaching our care and bringing in a trauma-informed approach. And we can do that through telehealth as well, okay? When we're thinking about multidisciplinary, here are some of the areas that they do recommend for people to get if they're experiencing more significant long-term impacts related to long COVID, just to kind of note that. And all of these areas of care are being provided, even with a long COVID specialty niche through telehealth. In fact, that's where a lot of it you'll see is some major university hospitals will have telehealth like inpatient or provider units that people can come in and see. But a lot of it's now telehealth. It's all accessed online and through like very specific hospital run groups and chat groups as well. Okay. Next slides. I'm going to just go over just these really briefly because I don't want to put up too much time into this. These are the actual tips for providers and agencies to have when it comes to thinking about long COVID. So I had them on here just because I think it's easy access for you all to see them rather than going and search from these. These are what is recommended as best practice for all agencies and providers to look at, okay? In specific, they have noted primary care providers need to be doing this because they are the ones who see the first line of patients typically rather than specialty health. But I say, think of this for everybody, right? No matter what agency you're in, or if you're a private practice person, consider these tips. So this one's really about listening and validating related to patients. Next slide. It's also emphasized to do telehealth, if you saw in that last slide. Then also look at an evaluation of symptoms. If they do mention about COVID and experiencing that, and if it's at all been with an increase in symptomatology, you might want to look at evaluating it further. There is a huge emphasis in evaluating things like energy levels, and then of course, sleep. We know sleep impairment is tied to everything from an increase in substance use, right, to also an increase in suicide attempts. So it is really important. Sleep impacts a lot, even though sometimes people will have such long standing sleep problems. That's just how they function. So they don't know that they're actually impaired. Okay, so that's a common experience for people. They actually don't know and don't believe they're impaired. So it's really important to just check in related to their hours of sleep and maybe even consider a formal sleep evaluation or referral if needed. Next slide. Okay. Also, one of the biggest recommendations is teaching self-management support skills. Now, that's for almost every single thing we can think of as far as mental health, substance use, and chronic disease management. That recommendation is paramount. So it's really making sure that we're providing skill building to our patients, as well as trying to help them with resources and an interdisciplinary team if we can. Next slide. We also want to try to provide certifications if people really do need it. Long COVID is now a formal disability in the United States and in some other countries as well. So people do qualify for full ADA disability on long COVID now. So we do want to make sure that we're checking in. Most people, if they get the treatment, will decrease in symptoms. So that's good. And we are seeing that they do not have the disability, but there is a disability status for those who continue on with significant problems. Okay. Next slide. These next slides, again, are here for your reference. I'm not going to go over them too much. I just want to kind of click through. Let's just go ahead and click through a couple. So you see that each of these slides, thank you, have specific domains where it says patient symptoms. And then the next one will have different assessment tools. So let's go ahead and the next slide. And then the next slide. And they're
And
specific.
Dr. Manson, just
Yeah.
to let you know, I'm sorry to interrupt you. We are good in time. So if
Okay.
you want to take a little bit longer, we are good in time. So go ahead.
No worries.
Thank
Thank
you.
you.
Thanks.
So each of these are going to give you also interventions and coping techniques. So you're going to have some of the evidence-based techniques on there. So next slide. So you see they encompass everything from depression. Here's anxiety. Next slide to PTSD. Okay. And it gives you some of those screening tools. A lot of the screening on each of the slides, there is a screening tool that is evidence-based and easy to use for anybody to use. So anyone can implement it. And then there's other types of assessment tools that typically you might have to get training on. So that might be a little bit different, but they all have something like on the last one was the PTSD, where anybody can do that. You don't have to be trained. Okay. Well, you should know the tool, right? But it doesn't require a formal, specific title, license, etc. So you have OCD, and keep going. You have substance use screening, right? And specific interventions and strategies. Next slide. You have general psychological distress. Okay, looking at the PROMIS scales, perceived stress scale. Okay, and there's others. I didn't put everything on there, and some of this is pulled from Sam Zahersa's recommendations, just so you know. And the last one is on fatigue and sleep. Okay. So just recognizing, again, some of these pieces. Now, it is important to note that if you look at some of these slides, you'll notice cognitive behavioral interventions are one of the number one, along with motivational interviewing. These two pieces have been, tested worldwide. And I think it's over 63 different dialects and languages. So it is really important to know there are certain types of interventions that you might want to make sure that people are trained on or have familiarity with for your interventions for your populations. Next slide. And these have all also been tested through telehealth. So we have really good ability to say, yes, we can provide this service through this. Yes, the evidence does not show that there's a concern about doing this. So again, here are kind of a mix of these recommendations that were shown by those symptoms. And again, these have also been provided through different forms of telehealth care as well. I do want to emphasize routine management, ADLs and IADLs. That's your activities of daily living. So when I wake up in the morning, I brush my hair or my teeth, I take a shower, I eat, it's very specific, structured time. That is one of the number one emphasized recommendations for our population, is to look at backing up and doing routine skill building. So then in that routine, you can also implement if there's any other types of higher levels of interventions you might need for them. So maybe there's a harm reduction skills or plan that you have. You would implement it into their routine. So the real recommendation is start when they wake up in the morning. When you wake up, what do you do next? What's the first thing you do? Well, I get up and eat. No, before you get up and eat, do you get out of bed and get dressed? Right? Do you eat something from your nightstand table? Right? Get down to that so you structure those minutes. And when you do that, you can do it in brief interventions. And when we look at that in action, it's typically one appointment with someone you might get done with just their morning routine. Then have them implement that for a week and see how that is, see how that changes and supports them. Then maybe the next week or 2 weeks later, you do the afternoon routine, right? So it's not going through their entire day in one visit, right? It's really taking it small pieces. And that's really important because if they do have any of this symptomatology from COVID, we know that it's impacting their ability to be able to do their regular routines, and they get tired faster, okay? And so it is really important that if we implement this and bring in all of our other interventions into this, we can map it out and see, okay, they said they were getting tired here. So we're going to like back it up. The number one recommendation for you all to hear is not to stop them from going out and being around others or being with others if they're feeling fatigued and tired, because that leads to more isolation, disconnectedness. It is to get them out, but maybe not to do as much. So for them to be able to communicate with bosses, the school, their friends, that they have a reduced capacity to engage. So like, hey, and so that's maybe you all writing letters to the school saying that they need a reduction in what they do in the daily schedule of school. And then at take home work needs to be reduced and have a plan for that. And the same with work. So it is reduce the amount of work that they're doing during the day, but they still need to go to work. The studies show that if they're not going, there's an actual increase in symptoms, even though patients report feeling more rested and they feel better being at home. We're seeing that they're actually increasing in social anxiety. And so it's kind of like this kickback that's happening. And so people have been trying to support them to not do as much, but ultimately it's not helpful. So we do need them to be moving and getting out, but instead of unfortunately playing the sports that they love to play, if they can't do that, they need to at least go and be on the sidelines and support their team if they feel that fatigued and cannot participate as a kid. They need to still be there. That's better for them long term. Okay. So just kind of thinking about those strategies and those specific recommendations. Okay, next slide. Again, that emphasis of behavioral interventions, this just goes in that aspect that I was talking about related to school and work, those modified schedules. That's something that as providers of care, you all can write notes that schools and workplaces do have to follow. So just kind of emphasizing that ability to do that for patients and making sure that you do that. For schools, just to kind of, if you're familiar with accommodation requests, the request for patients that are experiencing these symptoms are similar to ADHD type accommodations. Okay. Next slide. We've seen a huge movement in an increase in cognitive rehabilitation for patients that are experiencing substance use and mental health. This is also being done through telehealth, and this is directly related to, we believe, that long COVID phenomenon. So since COVID, we've seen these increase in symptomatology, et cetera, that continues to be standard right now. And we've seen cognitive rehabilitation, which is exactly what I kind of discussed before. It's that slower rehabilitative, taking time, talking about their routine, working on ADLs and IADLs as well, and bringing in behavioral health support. That's what this is about. It's really doing that type of work. There are cognitive rehabilitation groups that are offered through like large scale entities like Mayo and Banner and other agencies as well. And that if people need that, they can also obtain that through telehealth. Next slide. If people are interested, there are some specific labs that are recommended to consider if you're a medical facility to kind of look into for people. These are specific that if they're experiencing an increase in symptomatology, that seems odd, you want to look into these because this could help lead to recognize, oh, maybe they've had an impact since COVID. Okay. Next slide. Next things are relaxation training. And then the next one, go ahead, next slide, is care and case management. We know that we need these types of services as part of what we do with all of our patients, regardless of where we are, right? We even need that ourselves as providers, right? Or as managers in the healthcare system or as educators, we need relaxation training in our own care and case management. Maneuvering through medical neighborhoods is significantly difficult and it's a burden trauma for most people as well. So having any ability to have patient navigators or other support systems to help them, especially identify ACE, DOH, even through telemedicine, is really great. In fact, most care and case management is now being delivered through telehealth care resources. So if you haven't done that, that might be a really great place to consider, and that's all billable as well. So let's go next slide. We know that there's lots of ability to implement telehealth services for behavioral health and substance use. There's been a lot of debate of whether or not it's going to be here to stay. Right now, they really believe that we are going to have a stability in having funding and having financial support for telehealth. There are lots of ways to use telehealth. I won't go too much into them, but if people have questions, I'm more than happy to go into any areas in specific. But we can do remote consultations with people, okay? We can do remote monitoring. We can do telepsychiatry, mental health services, substance use services. We can do remote diagnostics. So in specific, they have different types of imaging that can be done remotely, including lab tests can actually be driven out to most people's homes now. So there's a lot of things that can be done remotely. Even telestroke is actually seen significant success in the United States, all done through telehealth. Dermatology and dermoscopy is done through telehealth now. So again, there's so many different pieces that people don't even realize now that are being done in different ways, telehealth wise. Sometimes they have someone come to the house to help, but otherwise it's being done through their computer and then through handheld devices. And of course, lastly, there's remote rehabilitation and chronic disease management that we've been talking about as well. Next slide. If you're someone who's considering it, or you already have telehealth, really consider making sure that you have your roles and responsibilities related to telehealth mapped out, that you have all of these areas at some point are being checked in on, okay? So that's your clinical care areas, that you know what best practices for whatever it is that you're providing care for related to telehealth. You know that you have a coordinator or some coach that can really help engage patients who have difficulties, set them up successfully and be awesome, right? You want to make sure you're getting a lens through your legal and ethical and regulatory guidelines, your billing and coding with all of your extra kind of billing and coding requirements there. So sometimes you have to add extra codes for that. So making sure that you have all of those things written out for better reimbursement, okay? So just thinking about making sure that you have these things in place. And if you're going to offer it regularly and have folks that this is what they do, consider mandating continuous training. Maybe it's something you provide, maybe you link up with some other health systems, but there is free training that is offered through various agencies worldwide. So maybe it's even just kind of saying, we want you to attend their free webinars. Okay. Next slide. There are a lot of technological barriers that people have and privacy, security concerns. These are all those legal considerations. So there are some scripts that they do recommend that people pick up if you're providing telehealth and you open up that, picture with someone or you're on the phone with someone, you do need to first ask or have an app that asks for them. Are you in a safe place? Are you somewhere where you believe that you can share your information and don't have confidentiality concerns? Are you X, Y, and Z? So you want to make sure that you have those pieces there. You also want to make sure that you have that coach or that kind of helps people or sets them up in your office related to any technology barriers so that they can know they can use their phone. Studies have shown that most people in the United States, even individuals that are experiencing homelessness and houselessness, have a smartphone. In fact, there are also areas in the cities that you can get free smartphones to give out to patients as well if they don't have them. Now, they don't have cellular service, but they do have the ability typically to call 911, and they do have the ability to to obtain Wi-Fi, right? And be able to get that. So those are things that you might want to consider related to that, okay? Especially if you have populations that don't have smartphones or don't have technology. Now, if you have Frontier, we do know that there are some real digital divides there. And even in those areas, Wi-Fi sometimes is not able to work. And so there's real problems in that. And so then that turns to just doing telephone encounters with those populations, okay? So you can also use public libraries and community centers. So in those areas where you have that digital divide, there is already precedence for healthcare agencies and other types of specialty healthcare agencies to make deals with local libraries to get like a room just for their patients, so that they say, yes, we want to make sure our community has access. Sure, we'll save that room for you, on Mondays and Wednesdays, from 8 to, noon. And so patients will go in there, and then that's their safe place with Wi-Fi, and they'll use their device in there. So there's ways to kind of work around that, and that has been done in lots of states in the United States already. Okay. We want to make sure too, when we're doing any telehealth, that we actually purposely take the time to connect with our patients. So look, obviously I can't see you now, but try to do eye contact if you're on video, right? And then if it's not able to have good video and you have to turn it off, make sure to ask them about themselves. Get personal in some way to make that social connectedness. Because again, we know that telehealth can distance us, but it can also connect us. So we want to purposely establish rapport and provide empathy. So we want to do that so that they can feel that connectedness. Okay. We also want to make sure if there's any cultural or linguistic barriers that we're looking at for our population before we recommend telehealth as well. Okay. Next slide. There are different telehealth resources to consider. And so these are some of the recommendations to kind of walk through if you're considering bringing on telehealth, or if you're thinking about expanding. So you want to look at your different types of platforms or softwares. I typically recommend utilizing what's already established in your EHR if you have one. If you don't have an EHR, if you have an HIE in your area and that you're a member of, see if there's anything that is compatible with the health information exchanges locally, that HIE. And if not, then you want to look at, are you going to ever do an EHR? There are free EHRs out there. Some of them are not very well recommended because there's been leaks in their data systems, but others of them people have utilized well. But you can look at those pieces, or you can just look at purchasing things through like Zoom or other general scale platforms, but you have to do the ones that have the HIPAA compliance, of course. And so you want to be relying on education, understanding of your HIPAA requirements. So of course, if you're a healthcare site, you probably have a HIPAA officer or safety officer that's already established at your agency, even small. So they're going to be the one that you're going to task them with knowing and ensuring that there's HIPAA compliance with anything that you're doing through telehealth. Okay. There are also licensing and credentialing considerations. There are some states that have cross-state lines jurisprudence for licensed individuals to practice. And in some states, you can only practice for X amount of days or time with a person across the state line. So it is important to look at those guidelines as well. So you need to look at the guidelines of your state and have that written out. And I would say just put it up on a wall. And then if a person's in another state, you need those guidelines as well, because your state will dictate first what you're able to do in your state. So if the other state says, yes, you can come and do, stuff here, but your state says, no, you can't, it goes with your state first, then you look at the next one. So this is where it can get complicated for people. And then, of course, as I talked about before, you want to make sure you're really understanding your codes, etc., so that you're ready and can clearly be able to implement these services appropriately. Next slide. So there's lots of different types of telehealth resources. In fact, California actually has a really great California Telehealth Network, and they provide free webinars for people. And they're actually doing one, I believe, it's this week or next week. And so I've been part of their network for, since 2004, since 2004. So 20 years now, yeah. And so it's really great they have great resources, they have online pieces, and they have them to look at through all the United States, so statewide. So really look at some of those resources and make sure to kind of work together and look at what you need to get done. There's conferences, et cetera, that you can do as well. Next slide. I wanted to give you some of the large scale entity websites that you can go on to. There's lots of them that are out there. Okay. There's the National Consortium of Telehealth Resources and Centers, the NCTRC. There's the ATEA, which is the American Telemedicine Association. And then most of our state agencies or Medicaid offices will have specific telehealth recommendations and services. Next slide. Here's some more of those websites and resources. Okay. And then I know I've got to close here for questions, but just to kind of flip through these next few slides. These slides are just some different types of resources for finding different types of practitioners. Next slide. different resources for individuals who are specifically experiencing things like long COVID. And so I did highlight Bayer College of Medicine, UT Health, and Public Health actually all have noted programs for long COVID. And then next slide, more recommendations and support resources for long COVID. And then I have a significant number of references attached to this program. But let's go ahead and stop slide share here, because I'd love to just have it open it up to say, I'd love to hear any other questions. I'm at the 10-minute time. And sorry if I spoke fast for anybody. I do apologize. Hopefully you can go back if you
It
have any
was
questions.
great. It was great. Actually, it was incredibly, it was informative, it was clear, it was to the point. So thank you for this presentation. Me, for once, I had no idea that long COVID was now considered part of benefits for disability. That's interesting. Good to know. Is
Yeah.
that something that is happening in most states or?
Yeah, so it's now recognized as a federal disability for Social Security. So it's federally recognized. So that means all states have to recognize it. And so individuals who are experiencing long-term symptomatology can apply under long COVID for long-term Social Security disability benefits now. Now, there are state agencies that can assist them in doing that as well. And there are some specific recommendations. I can obtain those. I was part of a long COVID ECHO series for a couple of years with some experts around the US. And we actually had an individual come on and talk about the ADA requirements and how to walk through it. If people are interested, I can try to grab those slides and see if there's anything that are good to highlight for people in understanding it. So I can always pull that if people want.
Yes, that would actually be great information, great resources to have for our learners. And
Yeah.
also, I wanted to remind all of you that we are going to be sharing the didactic material that we share with you today during the session, and all the sources and the research material is there. And I would like to invite our participants right now to start adding some questions to our Q&A chat. And I see a first question here. What is the name of the telehealth organization in California? I think we
Yes.
have that in the didactics, though.
Yeah, I believe it's also on there, and I don't want to miss it. I was actually going to just look it up because I had them. I recently actually just posted on my LinkedIn. I try to post them on my LinkedIn page, because I work with them on and off. It's the California Telehealth Resource Center. And so California Telehealth Resource Center. And so you can join their LinkedIn page if you're a LinkedIn member, and then you can get their info. They may also have a Facebook or other social media. I'm more on LinkedIn. You're also welcome to join my LinkedIn page at Lesley Manson, PSYD, and I post them on there too, and any of those. But you can follow that and you'll get all of their info, or you can get their like newsletter that they have as well.
Thank you. Thank you, Dr. Manson, for sharing all that information with us. Any more questions from our community today? Please use your Q&A chat box. We also have some questions over here. There is someone who's asking specifically, what if you could speak a little bit more about that scheduling, the use of the time, and why does that have an impact in persons who are trying to recover from COVID?
Yeah. So two things. We know that it actually is really helpful for most people to do it. And that comes from a lot of the motivational interviewing and self-management skill building research that's out there. Because what we know is that our ability to have a action plan or goal is really most successful is if we can see ourselves doing it. So we have self-efficacy, and it is built into something that's doable. If we say, hey, go ahead and put this in, you're like, yeah, I can do it during that moment. But what happens in that moment is you end up doing something else because something else comes up and it's more important. So it's about really scheduling it in to their daily routine. So we see a lot of research, and if you can break it down to those simple tasks, then people will like end up making it part of their routine and they're more likely to do it. So there's that research. Then for the long COVID, how it's impacting all of their body is just kind of think about it. I'm saying a lot of it in layman's kind of understanding, and I find I understand it best in that way, is it's really putting on this autoimmune effect on all of our body and what our ability is to manage and cope with things. So here we have a harder time moving through our day in various ways, thinking, making decisions, emotional regulation, but also physical regulation. So if during the day, what used to be really easy for me to do now becomes harder. So what we see is people who normally would get up and have a shower, make breakfast, and go to work. They're saying, I get up, I don't even want to get my coffee. It's so hard for me to take a shower. I get to work and I'm already exhausted. I have cups of coffee now, or I have 3 now, and I still feel like a heaviness, or I just feel tired. We see that type of picture of that fatigue a lot. We also know that there's patients with COVID that get POTS. That's a specific condition that happens with your heart and heart rate and how it operates in your body. So we see that when they are standing, so when they posturally, when they stand up and then they move, they actually have a significant decline. And so what occurs is that they have more fatigue and more fainting spells. So you can see this and it'll be random. It's not every time they're awake and up and moving, but every once in a while, we've seen a significant increase even with kids with this, is that these kids with long COVID, they'll be at school and then once a month, they're literally almost passing out or fainting. They'll fall down to the ground, okay, and at school. And so they're being sent home and they're struggling, they're feeling tired. These are kids that were on sports teams doing all of these things. And now they just don't want to. So we also see how it's presenting in care, especially for mental health, as we're getting a lot of more referrals for depression, anxiety. And so these kids are giving like, I just don't want to. And then they're trying to figure out reasons. So they'll be like, oh, so-and-so doesn't like me. Or so they come up with reasons, right, of why they could have this, because they don't know why they're experiencing this, right? So we all try to rationalize. So then it becomes more, we're diagnosing more depression, anxiety, and we're missing this. It's not that. Hopefully that makes sense, right? So we're noticing now that when we're going back to some of these populations, we're seeing that they're being diagnosed with having major depressive disorder as a child, really early on, that we've never done before, and having these more things. And it's actually COVID. Now, do they have those symptoms? Sure. Where do you want to draw the line of diagnostics? That's up to the clinician. But if we don't see the COVID, we're missing the long term of how we can treat it differently. So with major depressive disorder, we're looking at meds, right, and some CBT. But with long COVID, we'd want to go back and do this very specific thing of going, no, more rehabilitation. Look at this as the long term for that adult or that kid. Go back to think about micro interventions. What can we do when they first wake up? Instead of jumping out of bed, which actually could be contributing to things like POTS or other problems, sitting up, making sure they gather themselves in their bed for 1 minute, do some breathing before they get out of bed. Then they can put their legs down and stand up, right? These micro recommendations can lead to more success. And then specifically, what are you going to do when you're sitting in your bed? What's the next thing? And so it's all about trying to leverage their ability for their body to be able to maintain more levels of movement, but at a slower pace. The more you do that, and then after a month, you increase it a little bit. After another month, you increase it a little bit, then you're seeing success. They say to increase their workload or their functioning load every 4 to 6 weeks. So you find a baseline that's reasonable, and then you increase it. There's no like incremental schedule I've seen. I've seen people make up their own, but I haven't seen anything that says best practice 2 homework pages versus 3, or 1 hour extra of solid work time. I haven't seen that. I think that's just because we're also specific people, but just kind of thinking about those recommendations so that inherently, if you continue to do that, you're rehabbing their full system and how it's working all together so that they can take on more and function more, so they can think through things more, they can tolerate more emotions and do more emotional regulation, and then they have the physical capacity to do it too. Because of how it's all linked in the brain, we need to do that. So it's similar if you're familiar with the PTSD studies, through like they did fMRI studies 30 years ago, something like that. And they continue to do some every once in a while. But if you're familiar with those, they've done the same thing where they do these very specific, mandatory, this is when you're doing your breathing, this is how you're doing these specific techniques. And they actually see the structural changes in their brain happen. That's where all your plasticity studies have come from. It's very specific. So we know our brains have plasticity. So we know we can get them hopefully back to success for most people most of the time.
Wow, this has been great, great suggestions, great ideas. And I'm glad to see that there's some serious research going on, especially when you mentioned neuroplasticity. That is so, and everybody's talking about neuroplasticity right now. Thank you so much.